Hello, good afternoon, everybody. We are very happy to see you here this afternoon. Today, our session is about age-related macular degeneration. We are aiming to be a light session after lunch. We hope you all will enjoy it. As you know that the management of age-related macular degeneration has been rapidly evolving over the past decade. The advent of OCT and also anti-VEGF therapy has revolutionized our AMD treatment. And as you know, there are different treatment protocols, and there is no like a standard protocol. Some people prefer specific protocol, some people change from one protocol to another, some people aim for a tailored treatment. Our guest speakers today will address that, and we'll also have some presentation about new modalities of treatment and newer anti-VEGF agents as well. So, Dr. Sungul, I guess you have a special treatment protocol. Can you please tell us what is your treatment?
Thank you. We have many new treatment regimes emerging for the last years. And one is monthly injections. You know, we started with monthly injections, and then some fixed dose with wider intervals has emerged. Then some individualized treatments has emerged after that. These individualized treatments can be done by using PRN treatments, which is as needed treatment, or can be done by treat and extend regimen, or wait and extend regimen, or lastly, observe and plan regimens. So I will try to revise all these things for you. First of all, we learned anti-VEGFs to use monthly, starting with Marina and Anchor studies, and we know that the results were really surprising, very promising for us. And the results were really nice, but monthly treatment is not suitable for real life. Then we searched for rare treatments like fixed dose with wider intervals. This has been tried in many studies. PIER was one of the first, and they injected anti-VEGF every 3 months, quarterly fixed dosing. But the first early gained vision could not be maintained with 3 monthly injections. Then it was much inferior to the monthly injections. And another every 3-month injection was used in EXCITE study. It was a bit better than PIER study. The results were a bit better than PIER study, but still was less than monthly injections. But there was good news that 42% of eyes in extend study was preserving the early gained vision. So that means that this works in some of the cases, but for the rest of the cases, the visual gain at the beginning was lost during the follow-up. So any fixed regimen has the potential to over or under-treat the patients. So we need an individualized treatment. This individualized treatment plan can be done by PRN, treat and extend, wait and extend, or observe and plan regimens. For PRN treatment, we see the patients every month and treat when the lesion is active. But the number of injections, although the number of injections are less than monthly injections, the visits are still monthly, and it's not a proactive treatment. So you treat the lesion when it is active. It has been tried in many trials, studies, and Pronto was one of the first, but it was a small study in 40 patients. It was a unicenter study, but the result was really amazing, almost like monthly injections. But sustained study used PRN regime again, but results were inferior than Pronto. And Sailor study also did not so well. So the first gained vision could not be maintained through the follow-up. But this was probably because they used 100 microns of fluid change in OCT as a retreatment criteria. But in Arbor study, when they used more strict criteria for activation, they injected in any sign, with any sign of reactivation, then PRN regime was almost equal to monthly injections. So the results were better with almost equal with PRN injections. Another good news was that in sustained study, 20% of patients received no treatment following the first 3 injections. And another 30% received only 1 or 2 injections during the first year, which means that 50% of patients need only 1 or 2 injections after the loading dose. That's good news, actually. We have some patients like that. Then CAT study also had a PRN treatment treatment arm, and that was also similar to monthly injections. And then we searched for proactive treatments, which means that you inject when you have an activation. It's not a proactive injection, but if you treat the eye just before the activation, it's a proactive one. This gives us an advantage of avoiding from damage with a new activation. Treat and extend dosing regime was using this idea. You start with monthly injections until the lesion is totally inactive. Then we lengthen the treatment intervals by 1 or 2 weeks if there's no sign of exudation. And if we see a recurrent exudation, the treatment interval is reduced to the prior interval. So that you end up with an individualized treatment interval. But you shouldn't increase the interval more than 3 months for this regime. The number of visits were much lower than PRN and also monthly injections, but you have to treat in every visit. So that means that you are treating some of the patients more than they need. And Lucas was the first study using treat and extend regime for AMD cases. As you see here, the visual acuity gain at the beginning was maintained through the follow-up, through the first 2 years, and number of injections and visits were quite comparable to PRN regime. And this is one of our cases. This was a 70-year-old man. He had this kind of lesion. Then we started with 0.2 vision. He had 4 ranibizumab injections until getting dry. And then we started to increase the intervals between the injections. We injected every time in every visit, as you see here. Then with 12 weeks, it was still dry, so we are injecting every 12 weeks for this case now. And this is another one, 9 months follow-up, and the number of injection and visit was just 6. We started with 0.2 vision. We ended up with 0.8. You see, after getting dried with the first monthly injections, then we increased the treatment intervals. So what's the disadvantage of treat and extend regime? You over-treat some of the patients, because we know that some of the patients, almost 50% of patients, do not need so much injections for a year. But for this regime, you have to inject every time you see the patients. And there's another regime called wait and extend regime. In this one, you start with loading dose, and you do injections, monthly injections, until the lesion is completely dry, and lengthen the visit intervals by 1 or 2 weeks if there's no sign of exudation without injection. If you don't see any activation, you don't inject, but you only increase the treatment intervals. And if you see a recurrent exudation, you do monthly injections. And the maximum visit interval should be 8 weeks, which means 2 months for this treatment regimen. And this is a study done by Arias et al. And they have used 90 eyes, and they followed for a year. Mean number of injections was 4.4, and mean number of visits was 8. And there's another study, which was a multicentric study from Turkey. It was on AMD cases again. I was one of the investigators in that study, and PRN regime was versus weight and extent was examined for this study, and the number of visits was less in weight and extent regime, and the number of injections were almost equal or a bit less in weight and extent regime. So it worked. And another one is observe and plan regime. In this regime, you first give 3 loading doses, and then start to observe the case. If there's any sign of exudation, you do the injections again, 3 monthly injections. If it is dry, you continue to observe the case. You see a treatment plan here. As you see here, if I can use a pointer, is there any pointer here?
Maybe.
No, not it. Okay, you can follow it, I think, from the scene. We do 3 monthly injections, and if there's no sign of exudation, then we observe monthly, and thank you. Okay. You observe monthly, as you see here, and if it's a quiet one for 3 or 5, 6 months, then you increase the observation intervals also. But if you see any sign of exudation, you give another 3 injections, which is 2 weeks less than the prior interval. But you give 3 injections every time you see an exudation, and you increase the interval of injections every time you see it's dry. So you have a schedule like this, and they have done this in a study, observe and plan regime, and 19% of patients had 1.5 monthly intervals, and another 16% had 2 or 2.5 monthly intervals, and 18% had 3 monthly intervals. And the mean number of injections was 7.8 during the first year, and mean number of examination was 3.4, almost 4 during the first year. So this is to say that you have less treatment than monthly and treat and extend regimes, and less visit than monthly and PRN injections, and it's also a proactive treatment plan. So it looks quite fine to us. So our purpose is to minimize the number of intravitreal injections and also the visits and the tests. But we have to maintain an exudation-free macula with the fewest number of injections. So we need to perform the injection just immediately prior to the next recurrence. This is the best one if we can. To do that, we should predict the recurrence interval for each case. What I do is, after a couple of years of experience with PRN or maybe treat and extend or wait and extend regime or observe and plan regime, a treatment schedule can be extracted for an individual case, and then you can plan the injection intervals for that individual specifically. But not all the cases have regular recurrence intervals. Unfortunately, there's a study on that. All recurrences occurred at regular intervals in only 41% of the eyes. But that was an old study. Maybe this may change. But I just want to share a case with you. This was a 75-year-old man. This was the only eye, and he had 0.1 vision. And it was the picture like this at the beginning. Then 2 years of PRN treatment. We had 10 ranibizumab injections, and vision was just 0.2. Although there was no exudation in OCT, there was no scarring. The vision was only 0.2 during the dry stage. Then we formed another planned for him because the recurrence interval time was every third month. Then we planned visits and injections every 2.5 months for this man. And at the end of this is individualized treatment schedule. And at the end of additional 3 years of fixed treatment, by injecting every 2.5 months, vision increased to 0.5, which was very surprising for me because it was 0.2 even during the exudation-free period. But since we didn't let any new exudation, any new activity of the lesion, it didn't cause any more damage to the macula, and now he can see 0.5 with this regime. So we have the advantages of proactive treatment, and we have the advantages of less treatment than monthly and treat and extend regimes with this individualized treatment approach. But disadvantage is less than half of the cases has regular activation intervals. So as a conclusion, we need to decrease the number of visits, tests, injections while we are preserving the gained vision and to have a dry macula. And individual treatment regimes seems to fit very well for this purpose. Observer and plan looks advantageous with all of these regimes. Thank you.
Dr. Sengel, I have a quick question for you. Can you guess from the beginning which case will need more frequent injections? I mean, is there any signs to look for or to expect from OCT or from clinical appearance?
I'm sure I know the answer of this question very well, but there are some clues for me. Those with big PEDs are not doing well. They usually need very frequent injections, I can say that. And those who started with huge hemorrhages may be also problematic and may need more injections in my practice.
Oh, thank you. Is there any question from the audience? Yes, please. We have some time in this session, so we are aiming it to be more interactive. So please actively participate.
I've got a question because what I noticed in my patients that requirements for the drug may change throughout the years. Mm-hmm. And for example, I have patients who require less injections, and after 2 or 3 years, the number of injections should be adjust to the drug requirement. How can you deal with such a situation, having in mind that you kind of tend to give the fixed schedule? Mm-hmm. Of injections?
Yeah, you're talking about tachyphylaxis tolerance-like reactions, I think, Agnieszka.
Not really. It might be like that, but not really. Sometimes you can achieve the good result when you just increase the time, shorten the intervals. Mm-hmm.
It's actually a result of some kind of, tolerance. When you decrease the intervals, you get better results. That means that you have a tolerance, so it needs more drug to overcome the same anti-VEGF.
What I'm trying to say is I can imagine that it's very difficult to foresee when the next showing of the disease would appear. That's very kind of tricky, I would say.
You're right.
Yeah.
At the beginning, you can start with a very, very good response to anti-VEGF, but later you may have to think about switching to other anti-VEGFs, or you may think about decreasing the intervals. That's why at the beginning you start like this. But if you see any sign of exudation before that, you have to change your regime to decrease the intervals for every case. So that's why it should be individually arranged. That's what I'm talking about, actually. But you're totally right. And activation intervals are not the same, not fixed for everybody. You know, sometimes you have you need 6 injections consecutively. Then the patient is quiet for 6 months sometimes. So it's not regular in every case.
Yeah, please.
I'm in the camp with Frederick, who spoke 2 days ago. I feel that we overtreat these patients. And it's not just my opinion. You know, Genentech published a 7-UP study, which is a 7-year follow-up of the Sailor and Harbor patients. And it showed that good vision was maintained after 7 years. But the other interesting fact in that study was that after year 3, the average patient only needed 1.5 injections for the remaining 4 years. So I don't know where this 3-month caution window comes from. I have lots of patients that have gone out a long time, and they'll come to me 2 years after the last injection, and I say to them, think of how many unnecessary injections you would have gotten if you went to someone who followed the cookbook. So I tell my patients, you need as many, you should have as many injections as you need.
So you mean some of the patients does not need any treatment after the first
correct.
loading dose?
I feel that this disease burns itself out. Most people need more than 1 loading dose, although I do have 2 patients I can think of that I've given 1 loading dose to, and it's been one's 6 months, one's 9 months. They have not recurred. But most patients need more than 1 loading dose. But I think that you reach a point where the disease burns itself out. And I think it makes sense intellectually, because we know from the DRCR study that anti-VEGFs ameliorate the course of diabetic retinopathy, right? That's why people need half as many injections in year 2 than in year 1, and half as many in year 3 as in year 2. And in diabetic retinopathy, the VEGF levels are higher than they are in macular degeneration. So if anti-VEGFs will ameliorate the course of diabetic retinopathy, it makes sense to me that a series of injections, whether it's 3 or 4 or 6, should ameliorate the course of macular degeneration as well. And I feel very comfortable. I will say to my patients, and I'll stretch them out, and yeah, there are some that recur, but I'm hard-pressed to corroborate that the worst recurrences are after 4 months. I tell patients that the longer they go out, the less likely they're going to need an injection. Because when you think about it, if someone's at 6 months, do you really think there's any pharmacological effect of an anti-VEGF injection 6 months ago on their eye? I think everything's out of them by then. So if they made it to 6 months, their disease is quiet.
Yeah, I have an amazing case like that. She didn't respond to Avastin first, then I had to switch to Lucentis, and after giving 3 Lucentis, and I'm following her for the last 6 years, and she didn't need any other injection after that 3 injections. So that's why treatment extent, is sometimes over-treating patients. That's why I'm advising following the patient for the first 1 or 2 years, with PRN probably, and you can guess the prognosis of that case for that individual case. Not doing the injections every time, but just to observe what he goes like that. Then, if you see that he has recurrences again and again, then you can arrange the injections according to that 2 years.
My only point where I differ is that you get to a point and you say it's dry, there's no activity, but it's 3 months, so we have to give you an injection. So.
One last quick question.
All right, I think the situation is much more complex. The 7-year follow-up that Jeff just alluded to said that those that were most heavily injected and were the dry ones, actually the vision was returning toward baseline, that is, prior to treatment levels. And this was due to progression of the atrophy, the atrophic nature of the disease. And although the anti-VEGF companies would tend to reduce their concept of this, I think that this is much more complex, and sometimes some of that fluid that is under the retina. Certainly we want to avoid the severe rebleeds and the ones that cause the severe decrease in the vision. We want to avoid those. But some of those subretinal fluid, I think I'm now starting to suggest that we can differentiate a choroidopathy where the choroidal vessels are leaking and it is less lipoproteinaceous, so it's less toxic to the retina. So I think we've got to look at our OCTs in a much more complex way at the outer nuclear layer, the fragmentation of the PEJ, and all of these things, not just the subretinal fluid. But certainly we've got to find the ways to prevent those real severe reactivations that lead to the hemorrhage.
Thank you.